So for the panel, I believe talking about Temple or Chris, do you guys have a geriatric fracture program of some sort?
Yeah, we have one.
So if we could go, so Dr. DeLong and on over, what do you think the greatest barrier, if you could tell guys when they go back home, what's the greatest barrier to overcome when you have a geriatric fracture program? Who'd like to start? Dr. DeLong?
Well, the biggest barrier was the echocardiogram. That was it. If you have your internal medicine consultant, if he has to have a cardiologist come and see every patient to clear him for the operating room, you're going to get a significant number of echocardiograms. They don't do them at night, they don't do them on the weekends, and they hardly do them during the day. So it's a hard test to get, and then hard to get someone to interpret them. So we've learned that there are few cases that require them before hip fracture surgery, which is an urgent surgery. The buy-in by internal medicine is extremely important because they're taking a risk, they're adverse to risk. They want someone else to give the green light. And unless you get them on board and willing to push the flow toward the operating room, you really can't have success here.
Right. Chris?
Yeah, I would say that buy-in from the internal medicine doctors is key. We did have lengthy discussions with our internal medicine department, but there are still attendings that are more conservative than others, just like the attending that was involved with our case. But the reason why I think understanding how to risk stratify someone is so you can speak with that internal medicine doctor in their language. Because I think we do push, we say, hey, this needs to be fixed in 24 hours because it increases morbidity if we don't, mortality if we don't. They get other problems, but the medicine attending is not worried about all that stuff, as much as the arrhythmia or the heart failure or whatever. So you got to talk to them in their language. I think we've done a good job of getting these patients in the operating room within 24 hours, even within 12 hours. We've been able to do them the same day. We've been kind of running into some disposition issues with getting patients locked into a rehab center or a SNF, and I think that's the problem we're kind of dealing with now. It's not on the front end, it's the back end. So, working on it.
Talking?
I guess what I would add is maybe one of the barriers is getting buy-in from your administration that this is going to increase value, right? I mean, I think that we can all agree that an approach like this, a systematic approach, and we're in a checklist era now, so I think this type of approach, I think most people believe will improve quality. I think they clearly understand length of stay drops as a potentially improving quality, definitely reducing cost. But I think in terms of I think we all want to be able to keep a scorecard, but for instance, how do you convince the administration that, you got to give us good metrics, tools in order to track what's going on with the patients on the inpatient side, and then how do we also help transition there? We didn't really talk a lot about, transitioning to outpatient care and osteoporosis management, and I think the On the Bone program has been great. For some places, I think it hasn't necessarily had a return on investment, I guess. But so that's, I think, the challenge at many places. Like, how do you convince your administration to invest in either maybe bringing a consultant in to help design your program for you, or get something like CareSense that, nothing comes free. How do you, I think that's a long answer to say what I believe the challenge has been, and probably is at many places. And maybe Dr. DeLong can take that question. I mean, you guys have been very successful in getting a lot of buy-in at the administration level for investing in data tracking and, research support.
Well, the administration has to realize that quality is a high priority. It's a high priority for the government. And They understand that there are $2 or $3 million on the line at the end of the year in CMS payment. So you get an administrator's attention pretty quickly. And at our place, they bought in right away. I mean, I had no problem with this. This is about overall $110,000 investment with all three items. And the reality is it pays off in spades. We've got our full Medicare reimbursement since the program started, and we not only have gotten that, but we've been a Truven 100 top hospital for the last 2 years, and the geriatric fracture program is a huge part of that because we're avoiding catheter infections and central line infections, et cetera, just because patients are in the hospital for a shorter period of time. Care is focused, it's uniform. Everyone gets the same care, same order sets. You can't believe how much better the care is when you're really focused to provide it in a programmatic way. And this is something we probably should have been doing for decades. And this is driven partly by government change and partly by physicians understanding they have to improve quality. As I mentioned before, I was playing golf for 30 years, but not keeping score. I didn't know what my infection rate was. I didn't know what the outcomes were like with the patients I cared for. I thought it was great. I was the greatest surgeon in the world, but I wasn't measuring it. Well, now I am. And
You're measuring it, or you're the greatest surgeon?
oh no, I'm measuring it. You see, I was a warm-up for Haydel. You could tell where I stand here. Oh my gosh. So at any rate, this should transcend into everything we do, not only geriatric fractures. We use the data collection for joint replacement, for spine surgery, for everything we do. And we try to translate the organization of the geriatric fracture program into the other things we do. And I think it's very important. Uniform care, programmatic theming for providing the care is very, very important to provide good quality care. And I think if one thing Obamacare is doing for us, it's forcing us to do more of these things and to really look at ourselves and criticize our past work and translate into improvement for the future.
All right, thanks, guys. I mean, well, they're kind of echoing my own sentiment. I would sum it up as changing physician behavior. So physicians in the audience, I was asked by the senior administrator, when I proposed a program, why is it going to take so long? And I told him it was about a year and a half before we were really up and running. He got it in 6 months. Maybe we were at Abington within a year and a half, we showed some effect. Changing physician behavior. We've always done it this way. Why do we need to do it differently? What do you mean I have to see my patient today? Why can't I see him tomorrow morning? Well, because tomorrow morning for you means 10, and I'm trying to operate at 8 or 7. You need to see them tonight at 5 in the ER, not tomorrow morning on the floor. I always get echoes for all my patients. Well, that's really not necessary. Echocardiogram leads to delay. That's been proven, multiple institutions. So if I could sum up what they're saying, it's changing physician behavior. You kind of hopefully all here to get CMEs and learn and listen. Go out, take 1 or 2 things, and change your own behavior. Sort of that be the change you want to see in the world. So one part about this course, when Saku called me, maybe to frame what hey, we want to do this year. We're in an election season, right? So there's all these debates. Everybody's got an opinion. Is there going to be a wall, not a wall? Kick people out, keep people in. What are we going to do? So I've always interested to show people pictures, and then you get everyone sees the same picture, and then they do things differently. So many times, when we're out in the world, we all have our own eyes. We look at something, but your own brain and your own past experience, call it your bias, if you will. This is what you got to do. Oh, these all have to be done this way. Well, no, it can be done different ways. And at the end of the day, it's a patient. You're probably all right. It's just different ways of doing things. So that's when we get into sort of that debate side. It's the idea. Like everybody sees the same thing, but hopefully doing something different. So it's just going to go. I don't know what. This one. Oh, awesome. So, kind of going down the subtrochanteric femur fracture there'll be limited x-rays, but really no surprises. Let's call them that, we're talking about geriatrics, but we'll shift a little bit into trauma. It's a subtroch femur fracture. You get the 38-year-old male bicyclist hit by a car, otherwise healthy, admitted to, the hospital. Trauma's going to see him, admit him. So maybe keeping it short, Dr. Long, what are your thoughts and feelings? What are we going to do for this guy within the first 1 hour, 2 hours, 24 hours?
Well, the long bone fractures take priority. You have to understand what other injuries this patient has and what risks are going on. I teach my residents that we look at chest x-rays. We listen to what the trauma doctors say, but I'm going in the operating room, so I want to see what that chest x-ray looks like. If that looks bad to me, that's going to change the way I approach this fracture. I have to look at the other parameters, look at lactate levels. Don't let anybody tell you it's okay. Make sure it's okay for yourself. Once I decide it's okay to go ahead with intramedullary instrumentation, these things have patterns. A comminuted segmental proximal femur fracture takes special care. I don't struggle with these at all. I open them up, see what I'm doing. I gain control the way Saka suggested we should. You gain control of the elements with joysticks, with bone clamps, and get the fracture together. I have a tendency toward intramedullary fixation, but there are many of these proximal femur fractures that require a proximal femoral locking plate.
All right, we're gonna keep you short. Chris?
Yep, once we make sure that this patient is appropriately resuscitated, I agree. I like intramedullary nails. Indirect reduction methods, you'll have to worry a little bit more about rotation in this one, especially it looks like the lesser trochanter's off, so it may be kind of difficult to assess rotation by that method. But you got 4 big pieces there. You may be able to just reduce them with bone clamps and then place your nail, so you have your length, alignment, and rotation correct, but you don't have to make the big incision that's associated with the plate. So nail versus plate, Chris? I like a
your
nail
first
for this one.
nail. All right.
Piriformis nail.
Talk.
Yeah, I would do a nail for this. I would certainly try to get a closed reduction and then, if needed, percutaneous reduction. Some of the techniques I guess I went through. You just have to be honest with yourself. I mean, if you're really not loving the reduction, you have to obviously be prepared to open it as needed. This probably isn't a case, though, I would put lateral on a Jackson table and just say, I'm definitely just opening this no matter what. Because if I am, that's my preferred position and technique. I would put this supine where I feel like I have better control and assessment of the rotation, which I think you lose a little bit when you're lateral. I've also gone, like I mentioned, I have gone a little bit towards doing piriformis starts for more of these now to avoid that sort of lateral to medial trajectory. So that's really
Okay, I found that the Hanna table is really effective with injuries like this because you have the well leg on the other side and you could view it anytime you need to, and the table is out of your way when you're dealing with these proximal injuries. So that really facilitates.
Supine on the Hanna table.
Pardon me?
Supine on the Hanna table.
Supine Hanna
Yeah,
table.
you can go lateral on the Hanna table, but supine.
Yeah.
Okay. I'm trying to teach myself lateral nailing and then pass that on to the residents. For this guy, went on to a lateral nail. With lateral, we just talked about the AP of the knee and the lesser trochanter. Actually, if you teach yourself lateral nailing, get a good lateral of the femur, and then you should have about between 10, 15 degrees of version proximally, and then get a perfect straight up and down lateral of the knee, you've just dialed in your version. So you can pull traction. It'll sag into valgus. You can pull traction. If depending on the table you have, you can turn the perineal post up, bring up the guy out of valgus and up into anatomic, and then you can joystick a little bit easier. He went on to intermedullary nail. I left it all alone, and just sort of, my mom had a phrase, the dumber the farmer, the bigger the potato. So just by leaving it alone, you preserve that vascularity, and everything kind of knits back together. Stable internal fixation, fat titanium rod, let him put full weight on it. We're going to keep our interested in time. So the next patient was so this lady is late 20s. She's driving with her her husband, and they're playing, golf is our theme, I guess, today, Dr. DeLong. So she's driving with her husband playing golf. She lost her ball, though, and they're driving along. She says, there it is, and he turns really fast. She gets launched out of the side. So she's otherwise healthy. This is a bizarre injury, but she comes in with this, what called the reverse oblique proximal femur fracture. So now maybe not as high energy, but yet displaced, young active female. What would you do? Dr. DeLong.
So 20 years old and...
Late 20s, yeah.
Late 20s. Just from falling out of a cart.
Yep.
Yeah,
True story.
I'm concerned about the mechanism in the 20-year-old. I'm worried that there's an underlying cause for this failure, unless her husband was really speeding, and he did this with intent. So I'm a little worried
Yeah,
about
no red flags here.
quality of bone.
Okay.
This injury is one that you have to take seriously. I would get a CT scan, understand this proximally. I would have a low threshold for using a proximal locking plate or something that's more appropriate for a reverse oblique injury, according to the results of the CT scan.
All right, Chris?
I think you can go with a intramedullary nail with this one. I would definitely have a low threshold to open this up and just put a clamp on that spike, because it'll probably lock and key into that proximal fragment and not worry about the lesser.
I'm talking?
Yeah, I would nail this. You just have to make sure you're not in varus. Like Chris said, if you can get that to key in, I think it'll speed up your healing. Obviously, your reduction will be better. You'll feel better about it. But this can be a very challenging fracture. You could have a hard time reducing it. You have to be prepared to open. If you do get it open, it looks like you should get a very nice reduction. So you kind of have to say to yourself, is your reduction really good enough closed that you're going to sleep well about it, or because sometimes you'll open it and you'll still struggle a lot, and your reduction can still be a little bit off in a more comminuted fracture. But this one, if you open this, you really should get this, like, I would think almost anatomic or close to it. But anyway, I would nail it, and yeah.
So if you nail it, what's our rehab afterwards? Weight bearing, range of motion, what do you do?
Well, for elderly patients, weight bear is tolerated. My view on this is if they're young, healthy, and it's not a polytrauma patient, I don't see the advantage of making them fully weight bear on it right away. So I'll give them crutches. I'll have them toe touch or non-weight bearing, which ends up being toe touch anyway. But yeah, I'd get them up. But was your question just about weight bearing?
Well, mostly about nails versus plates. So if you nailed it, would you be more aggressive versus plating?
It's a very good question. I don't know if we have a good answer to that. It applies almost everywhere. Distal femur, if you nail it, does that mean you can weight bear it as opposed to plating? Biomechanical studies show plating is actually biomechanically stronger, yet we always feel if you plate someone, you're not supposed to weight bear them. We have our biases, but I don't know if the data, really supports that dichotomy the way we practice. Like you weight bear all the nails and you never weight bear somebody who's plated. And we weight bear people with a sliding hip screw, right? So.
But it's not fixed angle. Yeah.
But if it's isolated, yeah, you gave us an isolated femur fracture, so I'm not weight bearing them immediately anyway in a young, healthy patient who should be able to crutch walk.
Well, I'm getting the sum up light. I ended up plating, just to echo the sentiments. Again, it's like I'm putting up something, we're all looking at the same x-ray, what are you going to do? Yeah, we're going to clean it, clamp it, screw it, plate it. So open it, anatomic reduction, proximal locking plate, fixed angle device, if you want to put it that way. Some people would even, a blade plate here might remove a lot of bone. I don't weight bear plates in the proximal femur. I would say more of toe touch. She's young, healthy, she can tolerate crutches. That other patient, this guy, a little bit older, I weight bear the nails. There's some biomechanical evidence, in my opinion, it says you put in a big fat nail in there, you can walk on that even in the Windquist for femur fractures. That's okay. So that's my bias, is that you can walk on nails and not so much on plates. I weight bear my distal femurs, not my distal femur plates, my distal femur nails. All right, well, thank you very much to the panel. We'll try to do our best to stay on time, and I think Dr. Colling is coming up for the next session.